What's your emergency?
In the case of an emergency, there are 3 critical responders who are first to the scene: the fire service, the ambulance, and the police service. Working tirelessly to support our community, we meet face-to-face with these brave men and women who share insights into their departments, the roles they each play, and the key information you need to know in a crisis. This is 911 Emergency Bermuda. 911 Emergency Bermuda is brought to you by the Lindo's Group of Companies. Bermuda Hospitals Board comprises of the King Edward VII Memorial Hospital, the Mid-Atlantic Wellness Institute, and the Lamfogo Urgent Care Center. These organizations serve Bermuda's resident population of approximately 65,000 people, as well as the many visitors who come to our island each year. Given our isolated geographic location in the Atlantic Ocean, the Bermuda community needs a range of services far broader than would commonly be expected of a hospital serving a similar population. The King Edward VII Memorial Hospital's emergency department alone sees over 30,000 patients each year. There are numerous medical situations that might require emergency treatment. On today's episode, we interview several of Bermuda's top medical personnel who guide us through our emergency department and its procedures. We learn how local medical personnel are prepared for the increasingly violent emergencies Bermuda has been facing. Firstly, we talk to April Swan, Clinical Manager of Emergency, who outlines the admittance process and what you'll need to have with you to expedite the process.
My name is April Swan. I'm the Clinical Manager for the Emergency Department. I have been working for the hospital for 16 years. You should always carry your identification. There have been times that we have had patients come into hospital by ambulance and we are not able to identify them because they don't have their ID with them. It's always good to have a list of your medications so that we can ensure that medications that you are on don't interact with any medications that we may give you when you're in an emergency situation. So when you're coming into the emergency department, the first person that you will see is the triage nurse. And triage simply means to sort. So the triage nurse is responsible for sorting patients. They try to find the patients that are more urgent so that they can be seen first. So it's not a first come, first serve. The patients that have to be seen immediately are seen immediately, and the patients that have minor ailments can wait to be seen. So when you're checking into the emergency department, you will line queue, and you will be seen by the admitting clerk, who will register you into the department, and then the triage nurse will sort through patients who have checked in and determine who needs to be seen immediately and who can wait. Here at King Edward, we triage using the ESI levels, which is Emergency Severity Index, and the levels are 1 to 5, 1 being very urgent, meaning that you have no wait time, you're seen immediately. So that would be like a road traffic accident. They will come in by ambulance and they will be seen immediately. And then we have level 5, which is a very minor case. Maybe someone that could go to their doctor's office and they can wait up to 2, 4, 6 hours. Wow, it's many factors that can cause a long wait in emergency. So if a patient arrives by ambulance and needs to be seen urgently, then that may change your wait time for someone in the waiting room, because that particular type of patient will require multiple staff. So therefore, if all the staff go into that one person, the patients that are in the waiting room may have to wait. So the triage nurse will rate the patient according to their ESI level. So ESI levels determine how many resources you are requiring and how urgent your condition is. So it's the triage nurse's responsibility to ensure that patients that need to be seen immediately will be seen immediately, and the patients that can wait will have to wait. When you're coming into hospital, you can have 1 visitor. However, we do make exceptions. For minors, we will let both parents come in. For some elderly patients, we will allow 2 visitors. So it depends on the circumstances. So if you have a patient that is dying, we may allow family members to come in, but we'll do it in a safe way, whereas maybe 2 or 3 are coming in at a time. So if they don't see a triage nurse, then they're considered eloped. So if they leave, we can't find them, we elope them. Eloped patients shouldn't receive a bill. So in the event of a mass casualty, we have an A&P vehicle that we dispatch outside of the hospital, and they will set up a big tent, and then we will triage all the patients and determine who needs to come to hospital. Some of them may be treated right on the spot, and then we will also find what other resources are in that area. So for example, if a major catastrophe happened down in the East End, we may utilize the Urgent Care Center as a place to treat the walk-in wounded. And then the more severe cases will come up to King Edward. In all the years that I have worked at King Edward Memorial Hospital, the most rewarding part is knowing that I help people. And I really love my job. I really care about my patients. So that in itself is a reward. Our emergency department can compete with many hospitals around the world. We do have state-of-the-art technology, and we do have some great staff that work within the emergency department.
Coming up next, Dr. Edward Schultz, Chief of Emergency, informs us about the do's and don'ts of coming to the emergency department.
I was trying to make the point that this is a very small percentage of what we do. On an average day, we see somewhere between 85 and 100 patients in the emergency department.
Stay tuned for this and our ambulance ride-along when we return on 911 Emergency, Bermuda.
911, what's your emergency?
You want to be in a Linda's commercial? Or do you have any experience?
A little.
The name's Di James, straight out of Wales.
Have you ever worked with animals?
I have a pig, a fish, a cow.
So not much experience. Are you funny?
Some people say I am.
Can you say this? Linda's, why go anyplace else?
Lindo's, why go where?
Not gorilla flying. Do you like fajitas?
Not really.
Don't call us, we'll call you. Next!
Bermuda's #1 community cable channel, dedicated to local programming. So when you can't get out, we bring it home to you. You're watching Channel 82.
You're watching 911 Emergency Bermuda, brought to you by the Lindo's Group of Companies.
I'm Dr. Edward Schultz. I'm the Chief of Emergency Services and Hyperbaric Medicine at the hospital.
And how long have you been in this position?
It's a little embarrassing to say, but 28 years. Well, certainly acute, potentially life-threatening event should warrant a trip to the emergency room. So maybe we'll just start at the beginning and work down a list. Certainly an acute allergic reaction, if somebody's developed a rash all over, if somebody has swelling in the airway, that's certainly an emergency and that needs immediate care. People should dial 911 in that setting. If someone is having trouble breathing, and this might be someone with known respiratory disease or sudden onset of breathing difficulty, that's certainly a good reason to go to the emergency department. People over the age of 20 with chest pain would certainly, be a reason to go to the emergency room. The kind of things we worry about there would be a pulmonary embolism, a blood clot in their lung, less likely a heart attack in a younger person, an older person, that becomes a much bigger possibility. Someone who thinks they're having a stroke, and strokes don't just occur in elderly people, they can occur in young people too. We sometimes see strokes in women in their 30s related to the use of contraceptives and smoking. So, anyone that thinks they're having a stroke, that really is an emergency. There are medications that we can give patients to minimize the extent of injury if they come in early, but we have a 3-hour window in that setting. People with protracted severe abdominal pain should come to the emergency department. Everybody gets abdominal pain from time to time, but severe abdominal pain that lasts for hours should certainly warrant a trip to the emergency department. Acute serious injuries, uncontrolled bleeding from laceration, uncontrolled bleeding from a nosebleed, that would certainly be a reasonable reason to come to the emergency department. Children who are unwell, particularly young children who appear very unwell, who aren't interacting properly, that would be a reason to bring the child into the emergency room. Children with respiratory problems, significant respiratory problems. Very young children under a year with fever, that often warrants a trip to the emergency room, particularly if it's at night when you can't see the pediatrician. It would be preferable in those instances to see your pediatrician, but if it's after hours and your pediatrician's office isn't open, that would be a very valid reason to attend the emergency department. Well, there's really a vast difference, and I think there's a lot of misunderstanding in the community about this. The urgent care center, the Lamfogo Urgent Care Center, is basically a clinic. 2 of the rooms in that clinic are set up for resuscitation purposes so that in the event of a hurricane or closure of the causeway, that facility can act as a standalone emergency department under emergency conditions. But that's really not its scope or intent on a day-to-day basis. And the reason is this: there's no operating room at the urgent care center. So if someone comes in and they need a life-saving operation, we would have to transfer them to King Edward. We have very limited diagnostic capability there outside of doing plain x-rays, a cardiogram, checking someone's blood sugar. We really can't do much in the way of testing there. So if someone has chest pain, where we have to rule out the possibility of a heart attack or a blood clot in their lung, if someone has abdominal pain, where we need to do blood tests and possibly x-rays or a CT scan, we don't have that capability at the urgent care center. If someone is bleeding, if someone has a significant traumatic injury where they can have internal or external bleeding, we don't have a blood bank at the urgent care center. We don't have the backup in terms of specialist cover at the urgent care center that we have here at the hospital. So really, the urgent care center should only be attended by people with minor complaints. Anyone with severe chest pain, particularly a person over middle age with chest pain, they should go to King Edward. A person with severe abdominal pain should go to King Edward. A person who's having severe breathing difficulties where potentially they could end up being ventilated, that's someone who should go to King Edward. Severe traumatic injuries should be transported to King Edward. The kinds of injuries that you might want to present to the urgent care center would be minor lacerations, patients with upper respiratory symptoms, mild asthma, basically sprains and cuts, minor cuts and injuries. Patients and the population should remember that your general practitioner knows your medical history. He's probably taken care of you for many years. He has all of your records. He's familiar with your records. He has a great deal more knowledge about you than we're likely to glean in a rather brief encounter in the emergency department. So certainly if you're suffering from a flare of a chronic illness, if you need to have your medications renewed, those would all be instances where you should see your regular doctor. Chronic complaints should be seen by your regular doctor. We often see patients in the emergency room who've had knee pain for 3 or 4 weeks and come to the emergency department. That would be better managed by the regular doctor. The regular doctor might know that they shouldn't take certain medications that we might prescribe, such as non-steroidal anti-inflammatory medications. The other thing that we see a lot of times is families bring children to the emergency room during the day and during regular business hours. And really, if you have a pediatrician, that is a pediatric specialist. I'm always sort of amazed that people would choose to bring their children to the emergency room for a relatively minor complaint rather than see their pediatrician, who is trained specifically in dealing with problems that children are going to encounter. So those are instances where I think it's better to see your primary care physician. The real question we always have to ask ourselves as emergency physicians is, does the patient need to be admitted to complete the workup now, or can the workup of his medical problem be completed on an outpatient basis? With some diagnoses, it's very obvious. If someone comes in with severe chest pain and we think they might be having a heart attack, or if someone comes in with a stroke, obviously they're going to be admitted. Many times people present with vague complaints. These are complaints that may be long-standing, and we are often not able to establish a diagnosis in those circumstances. And then we're going to need to arrange follow-up either with their primary care physician or with a specialist physician. And we do that sometimes by going through the general practitioner if we can contact them. And it's not in the middle of the night and say, who would you like us to refer your patient to? We feel this patient needs to have an endoscopic procedure where they look in the stomach or they look in in the large bowel, or they may need to be seen by a surgical specialist. Who would you like us to see? If you look at abdominal pain, which is one of the most common diagnoses we see in the emergency room, and this is data from North American emergency departments, only about 50% of the time are we going to be able to establish a diagnosis for patients who present to the emergency room with abdominal pain. We try to rule out serious life-threatening problems such as appendicitis, bowel obstruction, and aortic aneurysm in older patients. That's really our duty, but there's many times where we're not going to have a firm diagnosis at the time of discharge. I always try to make the point that this is a very small percentage of what we do. On an average day, we see somewhere between 85 and 100 patients in the emergency department. Over the course of a year, we maybe see 50 or less gunshot wounds. So this is a very small percentage of what we do. Most of us have trained in centers where we were exposed to the management of gunshot wounds. I trained in Miami. Many of the physicians in our group have trained in major metropolitan areas where they saw a great deal of gun violence and significant trauma from gunshot wounds. It's pretty straightforward. You basically follow the management procedures for dealing with trauma. You know, if the patient's bleeding, they need to be stabilized in the operating room. If they're unstable, they need to be transfused if they require blood. Some of the lessons that have come out of the wars in Afghanistan and Iraq is it's better not to do a lot of interventions in these patients. It's better not to give them a lot of fluids until they go right to the operating room. And really survival times with gunshot wounds to the abdomen have been correlated from the time of the wounding to the time that person gets in the operating room. A lot of the visits to the emergency room we see could be prevented if people better manage their chronic diseases. Many people in Bermuda, unfortunately, have chronic diseases: diabetes, type 2 diabetes, asthma, chronic lung disease. These are diseases that require patients to take medication on a daily basis. Hypertension is another example. When people don't take their medications, when they're not compliant with their diet, this is what gets people into trouble. When they don't use their inhalers, when people smoke, when people drink excessively and then try to operate a motor vehicle. These are all situations that are going to set you up for really an unnecessary visit to the hospital. I mean, maybe quite necessary at the time, but the visit could have been prevented by simply doing the things you should do to take care of yourself. Well, it's very rewarding when we can help people, and you know, I would just say it's a joy to work here. People are really, really friendly. They're really, really nice. They appreciate the fact that we're there to provide care 24 hours a day. You know, that's tremendously rewarding. There are also times that it's very, very difficult to be an emergency physician. We see young people killed on our roads. We see young people killed by gunshot wounds. You know, we see children killed occasionally in accidents, and those are very difficult things to deal with and very traumatic events for the staff that work in the emergency department. The other thing about emergency medicine is you may have an event like that, and you know, and it might occur early in your shift, but then you have to go in and see another 20 people on your shift, and the next person may have a cold and they're in the emergency department. So, and they're angry because they had to wait because you were managing a patient that was critically ill or died. And changing gears is very difficult under those circumstances. It's very stressful for the staff sometimes, because sometimes, I will say most patients here are very understanding when we have major emergencies. But there are times that people can be angry that they've had to wait, and we don't have any control. It's not like a physician's office here. We don't schedule visits. We can get 5 visits in an hour, we can get 20 visits in an hour. Obviously, people are going to have to wait, and we have to see the sickest patients first. I've got fantastic staff, and we're really fortunate. One of the physicians who's worked in the department for many years is leaving to accept another post overseas, and he commented to me the other day that he thought the nursing staff we have now are some of the best we've ever had, and I would certainly agree. We have an experienced EMT staff that's been in the department for many years. We have very good emergency nurses. They're technically very good. We have, I think, excellent physicians. We have very experienced physicians. Most of them have been in emergency medicine for 15 or 20 years. And that's a tremendous amount of experience. Several of the people that work in our department have actually been directors of their own departments in the US or UK or overseas. I think the most significant trend we've seen in emergency medicine in the last 20 years is the increase in elderly people presenting to the emergency room with complex medical problems. And in fact, GP offices, internal medicine physicians often just send these patients to the emergency room to be sorted out. The fastest growing segment of the population in the developed nations are people over 80. They only make up about 3.7% of the population, but they make up 25% of the visits to the emergency department, and about half the time they're going to get admitted. Elderly people can present with very vague symptoms. Having bad feelings can mean anything that from being constipated to having a heart attack with no chest pain, no shortness of breath. And for that reason, they require extensive testing. The average older person, and I'm talking about people in their 70s, 80s, 90s, and it's not uncommon for us to see people over 100 years old now in the emergency room at King Edward. The average time it's going to take to work these patients up is 3 or 4 hours, and they often spend another 3 or 4 hours in the department after they've been admitted. So they have had a tremendous impact on bed flow. Even though they're a relatively small percentage of our patients, they've dramatically impacted operations. And this is projected only to get worse as we go forward, because more and more people are living longer and longer, which is great, but that means you're going to have more people with more medical comorbidities such as diabetes, hypertension. Many people are anticoagulated because they're at risk for stroke. All of these things take a great deal of time to sort out when somebody comes in at this age and is unwell in the emergency department. A lot of the times we see elderly people who haven't attended their primary care physician or haven't been compliant with their medications. And that's really, really important. And it's important to have routine checkups and follow-ups if you have multiple diseases, particularly diabetes, particularly hypertension. A lot of the strokes and heart attacks that we see are preventable. If people had basically controlled their blood pressure, controlled their blood sugar, kept their cholesterol levels in an appropriate range, we could prevent a great deal of morbidity and mortality in our community. And so, the trend is going to be people are going to be living longer. We're going to be living longer with significant disease. Fortunately, in medicine, we've made tremendous advances in the treatment of heart disease and infectious disease in the last century. That means our life expectancies have all increased a great deal. But if we live longer, all of us are going to run the risk of getting these chronic diseases that have to be managed, and they have to be managed effectively on a day-to-day basis. And if we don't manage those diseases, they really have the potential to bankrupt our entire healthcare system in Bermuda, as in every developed country of the world. So this is a big concern for all of us. The other question that often comes up is why is it important not to go to the emergency room if it's not an emergency? And there's a couple of really good reasons for this. And I think the most important reason is numerous studies have shown when the emergency room becomes overcrowded, and it's not the major factor in overcrowding actually is minor complaints attending the emergency room, but it does add to the problem of overcrowding. But when overcrowding occurs, sick patients wait longer to be seen. And that's something that we always try to avoid in emergency medicine. We triage patients to try and see the sickest patients first, but at the end of the day, if we have 20 people in the department, they have to, with minor complaints, they have to be seen at some point, which means when we're seeing those patients with minor complaints, we may not be addressing someone with a very serious, potentially life-threatening major complaint. And that's a big concern. The other issue that comes up, and it impacts every one of us, is the cost of emergency care is very expensive. It is almost impossible to come into the emergency department and be seen without a bill of $500 or $600. People can be seen much more inexpensively by their general practitioners or primary care physicians who have a much better knowledge of their medical history, the medications they're on, their allergies, experiences they've had in the past that patients sometimes don't even remember or recall when they're seen in the emergency department. They may not remember that they had a certain operation. They may not remember that they're on a certain medication, particularly elderly patients. So when people come to the emergency room for minor complaints that could have been handled much more effectively in their primary care physician's office, it raises the cost of health care for everyone. Yes, your insurance may pay for it, but when you buy insurance next year, your insurance rates are going to be higher. Yes, the government may pay for it, but those costs eventually are going to be passed down to all of us in terms of taxes or in terms of higher insurance rates. So there are two very good reasons not to attend the emergency room if it's not really a medical emergency.
Coming up next, Dr. Rosalind Bascom-Adams, Deputy Chief of Emergency Services, tells us what we need to do in case of disasters. Stay tuned for this and our ambulance ride-along when we return on 911 Emergency Bermuda.
Here in Bermuda, it's a one-stop shop. And so we have to be prepared to deal with anything that comes through our doors in any numbers at any level of severity.
911, what's your emergency?
Bermuda's #1 community cable channel, dedicated to local programming. So when you can't get out, we bring it home to you. You're watching Channel 82.
You're watching 911 Emergency Bermuda, brought to you by the Lindos Group of Companies.
I'm Rosalind Bascom-Adams, Director of the Emergency Department at King Edward Memorial Hospital. And I work very closely with Dr. Edward Schultz, who is the Chief of the Emergency Department. My role at the Emergency Department is twofold. I do work with the day-to-day care of patients, as well as providing guidance for management of mass casualties and disaster scenarios at the hospital. And I am partly administrative, assisting in the coordination management of the physician side of the hospital. In the role of disaster preparedness and disaster management, it is imperative that the hospital has a plan to continue to function and continue to provide care for routine patients, as well as managing the victims of major incidents that may occur. Every year we go through the period of hurricane awareness, hurricane season from 1st of June through to the 30th of November. And during that time, the hospital also has to have its awareness high, working in tandem with the Emergency Measures Organization of Bermuda, to be able to stay afloat, basically, and continue to function should we be tested by having a hurricane come close to our shores. From the patient's perspective, it's important that persons have their own home plans, just as we have hospital plans. Our hospital plans are designed to ensure that we have the supplies to care for any patients who come in, the staff to care for those patients, and the ability to safely house any patients that may be in-house. But you, John Public, have a responsibility as well. And that responsibility would include having your medication supplies at an ample level. If the storm causes a failure of electricity for an extended period of time, that you have medication that you can use. If your medication need to be stored in the refrigerator, you should at home have backup supply of an appropriate ice box or a generator if that is needed to keep your medication safe, just as you would need to keep your food safe. You will also need a generator if you have to use concentrated oxygen supply at home. At the hospital, we do make sure that we could provide additionally for persons who may be on concentrated oxygen at home. However, each individual has that responsibility, if they do need that continuous electricity supply, to have a backup generator if that is necessary. What I would urge is that for persons who don't have the capability of having that generator power and who know that they cannot do without concentrated oxygen on prolonged periods of time, that they come either to their family physician, report to their family physician for assistance, or come to the hospital ahead of the storm so that that backup supply can be provided. You would not necessarily be given a bed or a room during that time, but certainly we can give you a seat that is close to an oxygen supply so that you can continue to have that during the time that it is necessary. So knowing that what your needs are ahead of time and putting yourself in the position where you can get that supply should the electricity be interrupted is very important. We also know that during storms, the atmospheric temperature changes outside, and that can cause persons who have chronic pulmonary or lung problems to experience difficulty. So persons who are asthmatic may find themselves having difficulty breathing during the approach of the storm usually, or persons with chronic obstructive airway disease or COPD can also have difficulty during that time. So making sure that you have a backup supply of your inhalers is very important, and there is a possibility that you may need that added supply of a nebulizer. If you use your inhalers appropriately, the chances of needing a nebulizer goes way down. For us at the hospital, if a mass casualty is anticipated, for instance, a diverted aircraft with the possibility of victims on board, or an overturned bus with a number of casualties, anything that creates a number of victims that will overload our normal capacity will classify as a mass casualty incident. And if our normal capacity is likely to be overwhelmed in any way, then it's important for us to have provisions made for added staff, added supplies, added beds brought in to the area, whether it be the emergency room or the hospital generally, to deal with this surge of patients. So under my roles and responsibilities, I assist in the training of persons to deal with these emergencies as they arise, and to assist if we do have to deal with them, so that we can manage a surge of patients. We will need to change the way we do things on an everyday basis. So staff may be called in to manage patients in different areas. It may be in the field, it may be outside of the emergency department in the parking lot. It all depends on the size of the situation, the number of victims, and how serious those victims are. Some victims may just need to be stabilized in the emergency area. other victims may need to be taken to the intensive care unit or to the operating room. And we have to have checks and balances in place, whatever the situation may be, so that we can process patients as smoothly as possible. Our objective when we are dealing with mass casualties is to save as many as we can and to have as little morbidity as possible, or negative outcome, as little negative outcome as possible. We know that the nature of a disaster in itself means that we cannot save everybody, but we aim to save as many as we can. It is challenging working in an institution where there is just one hospital, I should say in a population base where it's just one hospital. In larger countries, they have the flexibility of saying, okay, we are full, move on to the next hospital. Here in Bermuda, it's a one-stop shop. And so we have to be prepared to deal with anything that comes through our doors in any numbers at any level of severity. And as those of you who have been medevaced or have had family members medevaced off island for care, you would know that it takes time to arrange that. And the timing can be anywhere from 10 hours to 24 hours in order to get a patient off island who needs that level of care higher than we are able to provide here in Bermuda. And so we have to be able to deal with patients in the initial phases and to stabilize them, to make them safe enough to tolerate a 2-hour flight to the east coast of the US. So there are huge responsibilities on Bermuda Hospitals Board in order to have things arranged in such a way that we can deal with our surge, that we can appropriately stabilize persons, and that we can take them overseas when our resources have been overwhelmed. But you, the patient, can help with that, because when there are major incidents, then keeping your visits to the ER as an as-needed basis is important. It's not important to come down to the ER to see exactly what's going on or to try to sneak in and find out what is happening. The important thing is to stay out of the way of those who are doing the work and give them a chance to execute things at the best way they could. It does not mean that we will not be able to deal with emergencies that occur during that time. Our plans are designed such that the heart attacks that occur, the strokes that occur, the severe asthma cases that come up, they can all be dealt with. And there's a system that we use to bring other patients with regular emergencies into the system and give them care with the level of urgency that is needed based on their particular situation. So helping us by coming only if you really need to will be a great bonus, and to avoid that natural curiosity that tends to surface among John public when these things occur. That will certainly give us a chance to do what we need to do at our end. It is also useful for you to know that when we are in a situation where there is potential for unstable situations around the hospital, for instance, if there have been a situation of a big fight, a shooting involved that may potentially spill over within the bounds of the hospital, we may need to go on what is called a hospital lockdown. And during a hospital lockdown, We discourage visitors. We ask persons who are currently visiting to leave the premises, and there will be very close control on any persons coming in and persons going out. This is done for the safety of victims, for the safety of staff, and for the safety of the general public. So if you are ever visiting the hospital compound, or you are a patient or within our confines and you are asked to leave because there is a hospital lockdown, then we would like for you to comply with that, because there is logic behind why we are asking that this be done. When we are preparing for a hurricane, just backtracking a bit, we do also technically go on a hospital lockdown. And that is slightly different from the type of lockdown that would be implemented, say, if there was a major shooting or unstable situations around the community. And that shutdown that occurs during a hurricane is really to make sure that all staff are in the confines of the hospital, and we would usually have added levels of staff. The critical departments would actually have double shifts in-house, just in the event that we have increase in victims during the storm, or following the storm, roads are anticipated to be blocked. And so it is useful to have our staff in-house ahead of a scenario like that. It's also important that I mention the urgent care center in this situation, because we know that this causeway is a potentially weak point for travel between the east end and the central part of the island. And therefore, ahead of a major storm impacting our area, the emergency department would usually send staff to the urgent care department, nursing and physician staff, and we generally would have a double shift. We will have the ambulance staff as well, the EMTs, and clerical staff is also needed. And those persons will be pre-positioned ahead of the storm, just in case the causeway is impassable afterwards, so that they can assist in providing stabilization during and immediately after a storm. Now, this is just stabilization. Remember that the urgent care does not have an operating room. It does not have a laboratory with the capability for blood transfusion. So we can temporize things, but we cannot do definitive care. And so it's important that you preposition yourself appropriately if you have a potentially tenuous situation.
Coming up next, we speak to Erlene Wilkinson, Security and Fire Officer, and Walter Brangman, EMT. Stay tuned for this and the dramatic conclusion to our episode when we return on 911 Emergency, Bermuda.
Ones that are deemed to be high risk or whatever, or if there's a large following, which usually tends to be, we will lock down the emergency department.
Has road traffic accidents increased? I think the culture of people riding on the road is contributing to accidents.
911, what's your emergency?
Bermuda's #1 community cable channel, dedicated to local programming. So when you can't get out, we bring it home to you. You're watching Channel 82.
You're watching 911 Emergency Bermuda, brought to you by the Lindos Group of Companies.
My name is Erlene Wilkinson. I am the Security and Fire Officer for the Bermuda Hospital Board. My responsibilities as it pertains to security and fire, my department is challenged with providing a safe and secure environment for staff, patients, and visitors to our facility. The Security Services Department comes under the remit of the Chief Operating Officer, Mr. Scott Pearman, who is responsible for all aspects of security and fire. We have a outsourced security force, and they are working out absolutely wonderful. They have a standard operating procedures manual which they work by, along with the policies and procedures provided by the Bermuda Hospital Board. The lockdown procedure varies depending on the actual incident that has occurred. As you know, the environment in Bermuda has changed, so we've seen an increase in stabbings, shootings, and violent crimes. Depending on the situation and after the risk assessment has been completed, we will then put certain measures in place which will see either a total lockdown of the hospital facility or a lockdown of the actual department in which the victim has been situated. Most likely what happens is an individual that has been a victim of violent crime will come through the emergency department. Once they are deemed to be high risk or whatever, or if there's a large following, which usually tends to be, we will lock down the emergency department, which means that persons that are coming to visit that individual or persons that have just been piggybacking off the actual train of the incident will not be allowed to come in. We do allow immediate family and possibly clergy. All other individuals, i.e. individuals that are coming in for normal treatment, will not be stopped from coming or entering into the facility. But we will be scrutinizing those individuals that are coming to be a part of or visiting the individual in the violent incident. As you asked about my advice during a lockdown for the members of the public, please note that the hospital still has to function as a hospital and provide services for not only the victim, but those persons that are here at the hospital. Therefore, we ask that crowds of people not attend the hospital because this will provide an atmosphere that may not be conducive to those that are here trying to receive treatment.
My name is Walter Brangman. I'm the Chief EMT for the Bermuda Hospital Board. I've been working here full-time since 2003. But prior to that, I used to volunteer as an EMT in the emergency department. What happens when someone calls for an ambulance? The caller initially will dial 911, and it goes through to the police dispatch in Prospect. That call is then transferred to the emergency medical dispatch that is located at the Bermuda Fire Service at King Street. And the caller would get the particulars and then relay that information by telephone to the EMTs in the emergency department. And the way the ambulance service now is that we actually have vehicles that are pre-positioned at the Port Royal station. So the call, depending on where the incident is or the person who is injured, they would either dispatch an ambulance from King Edward or out of the Port Royal station. How many EMTs are there in Bermuda? Officially, I think registered in Bermuda is probably about 120. We have 28 here that work either full-time or part-time out of the King Edward department. When should someone call for an ambulance? It's kind of difficult to say. And it depends on the circumstances. Everybody has a lot of people have emergencies. What an emergency to you might not be an emergency to me. But generally, if it's something life-threatening, we'd tell people, call and get advice. And usually the dispatchers will talk to the person. And this is why it is important for people not to get hasty and to answer the questions that the dispatchers have actually are asking them. And they can actually help a person decide whether they can either drive to the hospital or wait for an ambulance. But primarily, I mean, if a person has an emergency, call 911 and they'll be advised. If a driver's on the road and they hear an ambulance or a siren coming, pull to the side of the road and allow for free passage of the vehicle. What we don't want people to do is to stop side by side. And that only delays the ambulance's passage because we have to stop. And we ask people, try not to stop on blind corners. So that's the two things that we ask drivers not to do. And the other important thing is to do not to chase an ambulance. What happens, it actually distracts from the driver. The driver is worrying about the traffic that is oncoming, and there's also going to be worried about a person who might be driving too close to the ambulance. Because if the ambulance has to brake sharply, they're going to worry about you 10 feet from the back of the ambulance. And we don't want a person to be stopping to help somebody who's hit an ambulance when we're going to a very serious accident. It has happened. You can just see the dents that are in the back of our ambulance. And primarily we see bikes that are doing that. People want to get, the other thing, when we're coming back to the hospital, people try to follow us in order to get through the traffic. But it is a dangerous practice, which we would not do. And basically what the drivers have been instructed to do is that if we find people like that, it's just to take the telephone, not the telephone number, the license number of the offending vehicle and report it to the police. And they can be ticketed for that. How do I deal with dealing with a serious situation that I've dealt with? Pray. What we have available to us, what we call CISM training. We can call in people to help us to deal with it. And after every serious incident, we are asked, or I ask our guys, do you need help? And a lot of people think of the patients, but the staff also need help. And the community generally thinks that sometimes they were cool people, it's another day, another injury, but it does affect us. And one of the things about Bermuda is that it's a small community, and sometimes we're going out for our relatives. We could be going out for one of us. So it actually is a very stressful job. And we do encourage our guys to do extracurricular activities. Let them go to the gym, play tennis, and things like that. So that helps to relax them and to get the mind off, things like that. But we also stress to them that if it does bother you, get help. And actually what we also say, not only counseling, is also to get together as a group to debrief the situation. And we can talk about it, how we did it, and most of the times we can talk amongst ourselves to help each other. And that's what we say, talk amongst each other first of all, and call in help. Road traffic accidents is one of the most common reasons why people are calling for an ambulance. And also now with the community, the aging community, we're getting a lot of calls for them also. Has road traffic accidents increased? I think the culture of people riding on the road is contributing to accidents. We have seen a tremendous increase of it. But we're looking at statistics over the last year. We have less people here. So some of the accidents or some of the messages that's actually getting out to the community to actually take the time on the road, slow down, seems to be paying dividends. And again, it goes by season. Obviously, when you have a lot of tourists here during the summer, we do have more accidents. But I think the message that we can get out there is, especially for drinking and driving, slow down. If you have a drink, have a good friend who will be a designated driver. When an EMT arrives on the scene, especially at a house, the things that people can provide for us is medical history, medications, doctors, or any previous illnesses that a person has had, so that they can actually help the EMTs to help that person better. What does an emergency medical technician do? Well, basically here in Bermuda, we do a combination of jobs. Traditionally, EMTs do pre-hospital care. And basically that is helping anytime someone calls 911 is to respond to help them and do pre-hospital care, meaning dealing anywhere from childbirth to gunshots, road traffic accidents. Here in Bermuda, we're kind of unique, whereas the EMTs that work out of King Edward, we actually work inside of the hospital. So we do things, we're getting charts, we helping taking people to X-ray, to CAT scan. So it is kind of unique in Bermuda. The good thing about it is that as an EMT, when we bring a person in from a road traffic accident, we can actually follow them almost through to the whole treatment instead of just dropping them off at the door and leaving. How do you become an EMT? There are a couple of ways. The hospital, Bermuda Hospital Board and the Bermuda Fire Service, they do conduct EMT courses. Another way that can happen is that someone can go overseas to get training for an EMT. Now, there are different levels of EMT. One is the EMT basic, EMTI or advanced EMT, and EMT paramedic. And paramedic was just put on the books, on the legislation in August of 2015. One suggestion or one guide for people is that if they do go overseas, they should get nationally registered in the United States in order to come back and practice in Bermuda. What do I get out of doing my job as an EMT? Satisfaction that someone appreciates what we've done, and at the end of the day I can look back and say, did I do a good job today? And when I try to answer that and say, yes, I did the best I can, that's my satisfaction and my joy out of doing this job. And then my other thing that I enjoy doing is to help them to teach and to share my knowledge with other people. Would I encourage anybody to get into this field? Definitely. It is an exciting field. You never, no 2 days are alike. Today you might go out there and have a couple of road accidents, or you might have a gunshot victim, and then tomorrow you might go out there and you deliver a baby. And that is joy, and it's a smile will come to your face that you help to bring someone to this world.
Exclusively for 911 Emergency Bermuda, we take you into the emergency room where you experience firsthand the skillful care and efficiency of our life-saving emergency medical personnel. On next week's episode.
Right now, there's 91 firefighters, which includes 3 females who are actually working on shift. About 80% are all qualified at EMT.
In the first instance, what you want to do is to dial 911.
I'm the type of person that wants to see what I'm made of. I want to see where I fit in the grand scheme of things.
911, what's your emergency?